welcome our honorable speaker, Dr. K Susheen Dutt. Sir, he is MBBS MS Fellowship in Advanced Endoscopic Sinus and Anterior Skull Base Surgery. He did it in Singapore. And Doctor is a student and trained under the world's renowned surgeon. Everybody knows Dr. Narayan Janakiraman, sir. And Doctor is certificate training in cochlear implant and lateral skull base surgery from Italy. More than this, Dr. Susheen Dutt sir is closely working with Dr. Deepak Kaldipur sir, renowned name in the ENT fraternity, in various scientific and academic initiatives. Dr. K Susheen Dutt sir is currently working as a senior consultant ENT neck and skull base surgeon at Fortis Hospital, Nagarabavi and Bannerghatta Road. Apart from the regular spectrum of ENT services, he is specialist in middle ear hearing restoration procedures, cochlear implantation, endoscopic sinus procedures, CSF rhinoria surgery, minimal access endoscopic brain tumor surgery, and surgery of temporal bone tumors, surgery of CP angle pathologies, and phonosurgeries from voice disorders, and surgery from senior and obstructive sleep apnea. These are the core area of Dr. Susheen Dutt sir. And today, Doctor will going to speak on the rational use of Feropanam in ENT practice. Sir, the session is over to you.
Thank you, Bhaskaraji, for the generous introduction. At the very outset, I thank Microlabs for having me in this session today. It's a pleasure to talk about Feropanam. Good afternoon, everyone. This is Dr. Susheen Dutt from Bangalore. I thank Microlabs for having me to talk about a less spoken about molecule, yet it may have profound utility in our day-to-day practice, that is Feropanam. So what is the big discussion about antibiotics that happens every now and then? All of us know that microbiomes, microorganisms have threatened human life from times immemorial. So they are a leading cause of mortality and morbidity to the human race and also in the animals. Hence, the discussion is about the antibiotics, even in the ongoing scenario, becomes pertinent. So if you look at this antibiotic discovery timeline, you can see on the left, the penicillins came into existence in the year 1920. And then gradually there have been advent of other molecules, sulfonamides, aminoglycosides, etc. And slowly, in the 1970s, when the late 70s, when the carbapenems came in, pretty much the inventions or the discoveries in terms of the growth of the antibiotic molecules have pretty much come to a standstill. What we mean by that is that there is a large void in what we call now as the post-antibiotic era, wherein we are on the brink of exhausting all kinds of antibiotics. And we are kind of cornered, the human race is cornered. There might soon be a time wherein we might run out of effective antibiotics for bacterial pathologies. So we all have a great responsibility. Why is antibiotic resistance happening? So one is because of spontaneous development of antimicrobial resistance. The second most important reason is the inappropriate and indiscriminate use of newly discovered antimicrobial drugs that lead to resistance. And of course, with time, the microorganisms are very smart. They tend to develop different mechanisms of antimicrobial resistance, which in turn cause a major public health concern. So now, in this scenario, the antimicrobial stewardship comes in. What is antimicrobial stewardship? It is training the healthcare professionals and all the people involved in the care of the sick patients about the rational, appropriate, adequate use of antibiotics, how to use them, what is the dosing, when to stop, and also give them an idea about the optimal outcomes. So this antimicrobial stewardship, what we commonly call as the AMS, becomes very crucial if human race has to survive the dangerous infections. So when we talk about antibiotic resistance, we talk about two groups of organisms That is the hospital-acquired organisms and the community-acquired organisms. The hospital-acquired organisms, the most commonly talked about are MRSA or methicillin-resistant staph, vancomycin-resistant enterococcus, enterobacter. Pseudomonas is a major concern along with Klebsiella. Along with that, the community-acquired infections such as penicillin-resistant pneumococcal infections, ESBL, that is extended spectrum beta-lactamase resistant E. coli and Haemophilus, also become very pertinent to the discussion. So why are we talking about all this? See, we all know that there is a complex interaction between the humankind, the animals, and the environment. You can see it's a very complex set of factors. For example, if you start washing vegetables in contaminated water, that can lead to diarrhea, as you can see in the left part of the chain. And if there is some agricultural let off into the rivers, it can pollute the water, and it in turn can lead to various infection. Similarly, when the animal community acquires certain infection, and then these infections can affect the human race, especially when there is the weaker immune system, when there is malnutrition. These infections cascade into something very, very complex and difficult to handle. What this slide shows you is the summary of the interaction between the human, animal kind, and the environment, which leads to an infective process which can become potentially troublesome. So what are the current challenges in the treatment of bacterial infections? The common tracts that get infected are the respiratory tract, the skin and soft tissues, and also the urinary tract. So in the respiratory tract, we talk about beta-lactamase producing Haemophilus, Moraxella, and also penicillin-resistant streptococcal infections. The soft tissue infections are quite common in the surgical wards. So a successful management of these involves timely debridement, drainage, and also institution of appropriate antibiotic therapy. And also the uropathogens, the urological infections, which are most commonly caused by E. coli, can turn out to be a very dangerous and resistant strain. Like we spoke before, antimicrobial stewardship becomes even more important in the emerging clinical scenarios. So traditionally, these are the groups of antibiotics which have been available for therapies over the years. We are all familiar with them. Talking specifically about PENMs, so the Clinical Laboratory Standards Institute, or the CLSI, has renamed the carbapenem class of drugs as PENMs with two subclasses. So this looks a little controversial. So carbapenem is divided into two subclasses of PENMs. One is the carbapenem and the penem. So this, this looks a little contradictory, but that is what is the new classification. Under the carbapenems, we have the imipenem, meropenem, ertapenem. These are the common molecules you would have seen being used in the ward and the ICU scenarios. Among the penems, feropanam is the most important molecules, and it also has certain distinct chemical properties which sets it apart from the traditional carbapenems. So what is the penem? So as we would have heard of it, we have something called as the CIFAM structure. We have something called as the PINAM structure. CIFAM structure is seen in cephalosporin molecules. PINAM structure is seen in penicillin group of molecules. Now imagine having a molecule which can have characteristics of both CIFAM and PINAM. So when you amalgamate these two, that is when the PINAM class is born. And this PINAM molecule seems to have certain kind of superpower. We call it the hybrid power, or they can have powers which are over and above both classes of cephalosporins and penicillins put together. So this is the structure of the PINAM molecule, and this is what feropanam looks like. So what is very important is that feropanam, that makes feropanam of much clinical utility, is that it is the only orally available pinam. It can be taken in the tablet form or in the syrup form. So this makes it a good choice of treatment of many infections, as we'll see in the coming slides. So we know that Carbapenems are effective beta-lactam antimicrobials. In the sense, they have a good spectrum of activity against both gram-positive and gram-negative bacteria with a good spectrum of antimicrobial activity. However, what are the current concerns regarding the carbapenem group? So the resistance is slowly increasing, especially among the gram-negative group of pathogens. As compared to, say, feropanam, the carbapenems have not much stability to the beta-lactamase activity. And we also have the added discomfort of intravenous administration. So all the carbapenems are administered IV. We may not have an oral form available in the carbapenem group. However, they are potent, they're well tolerated, they're safe, and also there is less toxicity, which are the hallmark features of carbapenems. So, why does feropanam take center stage now? Because it exhibits a good broad spectrum antimicrobial activity against both gram-positive and gram-negative organisms as well as anaerobes, because it is practically resistant to hydrolysis by all kinds of beta-lactamases. Like I said before, it is the only oral penem antibiotic available, and it is also has a proven safety margin in children. There have been a good number of studies which have established the safety of these feropanam molecule in children. Not only that, the prodrug of feropanam is also active, so which in turn cascades into the overall efficacy of the feropanam molecule. So what are the advantages of feropanam? It can be taken orally, it is more stable, and as of now, the resistance to feropanam is fairly well controlled. So what is the structure of the feropanam molecule? Like I spoke about it in the past, so there is a certain chemical or biochemical correlation wherein the structural configuration of feropanam offers it extraordinary stability and advantages such as beta-lactamase resistance, and it also has a broader spectrum of coverage against gram-positive, negative, and also anaerobic bacteria. The AMC is one of the beta-lactamases produced by the gram-negative bacteria. Interestingly, feropanam is also able to fight that and also treat gram-negative infections. One of the key factors that help feropanam be an effective molecule is the small size. So what this small size offers is their ability to bind to the penicillin binding proteins. We have the bacterial surface has what we call as PBPs, or the penicillin binding proteins. So the penicillin binding avidity is quite high for feropanam in both the gram-positive and the gram-negative bacteria. And you can see the spectrum is quite good. Strep group, staph, enterococci, streptococci, and also gram-negative Haemophilus, E. coli, Klebsiella. So you can see these are the organisms which we commonly fight with. As clinicians, we have to struggle with these organisms in our day-to-day practice, especially those in treating sick patients in the ICU systems. The spectrum of action of feropanam makes it a favorable molecule. So how does it act? Like we spoke before. So they enter the bacterial cell and they bind to the penicillin binding proteins, and they prevent bacterial cell wall synthesis, meaning to say they break down the bacteria, they damage their cell wall and render the bacteria ineffective. So they have a good bactericidal activity. You can see the diagrammatic representation of binding to the penicillin binding proteins. So what is the spectrum of utility of feropanam? So as far as our specialty is concerned, definitely it is a good option for treatment of bacterial sinusitis, bacterial tonsillopharyngitis, and also acute otitis media. As an extended spectrum, it can be used in acute and also chronic bronchitis and community acquired pneumonias. Of course, the other skin and soft tissue and urinary tract infections pertain to the subsequent other specialties. One of the important utilities, like mentioned below, as sequential therapy. That means we can, if the patient is very sick, we can initially start them on the intravenous carbapenems, and as a step down therapy, we can switch them out to the feropanam when they're even more stable. The accepted dose is 15 milligram per kg per day in 3 divided doses. That means in a given dose, 5 milligram per kg can be given. So there is not much, hypersensitivity or reactions which can develop to carbon. They're relatively safe. Since they have a renal excretion, it is one of the important considerations for us to keep in mind about any renal failures or renal insufficiencies which can cause problems. So the good part is that it has a half-life of 1 hour, and then it has very good tissue distribution, and it reaches a peak plasma concentrations very quickly. That makes it effective in a short duration after oral admission. So you can perhaps compare feropanam to something like clarithromycin. Luckily, feropanam has not been used much, so to say, in the commercial sense. So that makes it, you can say, a precious antibiotic. Azithromycin has been rampantly used in the COVID scenario. Now, we have seen even in our day-to-day clinical practice that azithromycin is not as effective as it used to be. So now people are slowly looking towards clarithromycin. Likewise, there are specific clinical scenarios wherein our typical, co-amoxiclav or, cefuroxime might not work. That is when feropanam gets its opportunity, because it is effective as an oral drug, not only in adults, but also in children. So there have been good number of studies which have established that the feropanam has good stability against beta-lactamase activity. So there is low propensity for resistance with feropanam. Definitely it has stability while dealing with Staph aureus and E. coli, and the hydrolysis of feropanam by metallo-BLA enzyme is far lower than that for imipenem. In that sense, in certain case scenarios, it can score over the traditionally prescribed intravenous drugs. So this is a list of the minimal inhibitory concentration, MIC. You can see that feropanam for strep has a very low MIC. That means it acts really fast and really quick. It has the reasonable action in H. influenzae, in E. coli, and also in the Klebsiella species. So there have been in vitro studies on using feropanam against multiple bacterial lysates. So there have been multiple bacterial strains in which feropanam has been tried, and there have been studies, like I said before, that support the contention that feropanam has a good potency in organisms that have not shown much response to azithromycin, amoxiclav, or cefuroxime. There have been studies on the pediatric population. Like I said, the dosing is about 15 to 30 milligram per kg per day in 3 divided doses. So it has definitely demonstrated good potency in upper respiratory tract infections and also in the lower respiratory tract infection in children as well. There have been studies about how feropanam can help in children with acute otitis media. We would have seen certain group of patients that have biofilms in the middle ear pathologies, in the otitis media with effusion, and also in the acute otitis media scenarios. These children may not have responded to a long course of, say, co-amoxiclav or azithromycin. In these patients, in these children that come frequently to us, definitely I think it's worth keeping in mind that feropanam can have an extended activity and perhaps reduce the episodes. So these are all studies which collect the data from pediatric populations. And there have been studies that show that the feropanam is effective even in ESBL producing E. coli, and far higher efficacy in these scenarios. So why is feropanam the molecule with a difference? One, it is the only penem antibiotic that is active against gram-positive, gram-negative, and anaerobes. It's available in the oral form. It is stable against the whole range of beta-lactamases and also the ESBLs producing pathogens. And because of its small size, like we spoke before, Feropanam is able to bind in a better way, in a more effective way to the penicillin binding proteins of the bacteria. And there is also a low propensity to develop beta-lactamase resistance. So one of the important things that we need to keep in mind from this presentation is perhaps it is a good molecule for both treatment of community-acquired infections and for the routine upper respiratory infections, wherein it can serve as a step-down therapy or a sequential therapy following carbapenem treatment. So what happens is that when you use carbapenem, when you use the imipenem, meropenem for a certain amount of time, when the patient starts improving, we could use feropenem as an oral step down. What this does, it also reduces the chances of the organism getting resistant to the whole beta-lactam class. In that way, this serves a larger purpose to the community, that we are, being clinicians, we are avoiding or preventing development of resistance to the class of molecules as such. So why Feronac? Feronac because it is one of the good molecules with good oral tolerance, and we have both preparations in the form of 200 and also 300, the extended release preparations, and they have good efficacy, like you can see in the chart. In especially in our specialty, it can be recommended for use in chronic tonsillitis or recurrent tonsillitis. It can be used in persistent otitis media episodes, and definitely when there is a pneumonia, we can consider the feropanam as an important molecule for use. One of the things I would like to talk about is that there is not much scientific support here, but what we have seen, even in patients that have skull-base osteomyelitis, which is basically a pseudomonal infection, what we have seen initially after therapy with imipenem and meropenem is commonly used because of the easy dosing, 1 gram twice. When the patient starts to respond, when he or she starts to improve, though the potency of feropanam for pseudomonas is lower down the list, in the clinical scenarios, in the practical settings, what we have seen is that the granulations in the external auditory canal and also the bogginess of the ear passage of the ear canal as such, and also the pain and the infective symptoms seem to show good activity to feropanam. I have had the opportunity to use feropanam as a step-down therapy in patients that are being treated for skull-base osteomyelitis or malignant otitis externa due to the pseudomonal infection, and it has definitely shown a promising response wherein patients are happier when you step them down from IV to, all of us definitely want the best for the patients. We want them to use oral medications and be free of hospital visits. It has definitely, though the pseudomonal specificity is down the list in as far as the feropanam molecule is concerned, definitely in the clinical scenario, it seems to have some efficacy in treating these infections as a step-down therapy. So it is a good molecule for common upper respiratory tract infections in our specialty, and also a good drug, oral drug for step-down therapy when we want to wean off the patient from the carbapenem group of drugs. Thank you very much for your patient listening.
This one also.
Sir, thank you so much. Currently 415 ENT surgeons across India, they were watching live, and there is a question.
Yeah, as per the slide, maximum permissible dose is 10 mg per kg. A person is having a body weight of 100 kg. Should we give him 1000 milligram of feropanam? So what we normally do is when a patient is 100 kilos, we definitely want to see. We would like to start with a 300 mg dose twice a day, that's 600 mg. Do it for 2 to 3 days. Look at the renal profile, see how the kidneys are responding to the therapy. And then if the infection needs a step up, then maybe we can increase the dosage. But initially, I would go with 300 mg twice a day, and then step up if necessary.
Thank you so much for your enlightened presentation and rational use of Feropanam in ENT practice. And there is a small poll we are running for because we are almost approached 18 medical colleges. There is a poll.
Yeah.
We are running, sir.
So the question is that Feropanam is formed synthetically by a combination of penam and cifam nuclei, 2 penam nuclei and 2 cifam nuclei. Can we launch that question?
Yes, sir. Yes, sir.
Knowledge that why Feropanam can be a good drug is because it has borrowed the good characteristics of both penicillins and cephalosporin. The penicillin has a penam molecule and cephalosporin has a cifam nuclei. When both the nuclei come together, that partly answers the question also. So that is when you can have a good efficacy from the molecule.
Second question.
So the take-home message for the ENT community at large is that when you have a patient that has got a problematic, response to upper respiratory tract infections, commonly being acute sinusitis, adenotonsillitis, and also otitis media with effusion, otitis media with or without effusion, definitely it is worth considering the oral preparation Feropanam. When the conventional drugs that we use, I think by convention the first line drugs would be cefuroxime, would also be comoxiclav. So definitely it is worth keeping in mind that Feropanam can be chipped into these clinical scenarios to get a better clinical outcome.
So second poll, with your permission, we will release.
Yeah, please.
Poll is live, sir. Second question.
Right. Have you
Feropanam is the only member of the subclass of penams. Sir, the answer is 57% said true, 42% said false. So we need your view on that, sir.
What is the question, sorry?
Sir, penams is the only member of the subclass of penams. Feropanam is the only member of subclass of penam. As per the audience, 66% audience rated true, 33% audience rated false. So we need your view on that.
So now, as I think we went through that in the discussion. So Feropanam stands out as the only molecule in the penam class. Now, as per the new classification, we have penams and carbapenams. Under the penam class, so Feropanam is the undisputed leader as of now, until maybe further research can happen or further molecules can be added to the kitty. Feropanam is the only man standing tall in the penam group. So the answer is Feropanam only.
Sir, now the audience poll is went to 79%. They said true.
Yeah.
And 21% still they are in the false.
Yes.
And second one, sir. Second one, third question, which is in the poll, is penam is the distinguished from carbapenam by carbon atom at position 1 and sulfur atom at position 1. Sir, surprisingly, 100% answer is carbapenam atom at position number 1, sir.
Oh, fantastic. I think the audience knows a lot of biochemistry, perhaps more than me. So this is the unique property of the Feropanam, which gives it those unique properties. That is the correct answer. Fantastic that the audience is aware of that chemical structure as well.
Sir, there is one more question which our team received and posted in the group.
Yeah.
Is there any changes in developing antibiotic resistance due to long-term use of Feropanam, sir?
So what is happening now? Typically in the clinical scenarios, we are using Feropanam for up to about 3 to 4 weeks. And like I said, if we are looking at a step-down therapy in patients with skull-base osteomyelitis or other infections, or even the pneumonia and upper respiratory infections, in this scenario, the 3 to 4 weeks of therapy is all right. 3 to 4 weeks of therapy is all right. In the long run, we don't know what kind of mechanisms the bacteria are going to develop. At this point in time, like I spoke in the presentation, Feropanam can fight is resistant to all forms of beta-lactamases. Beta-lactamases A, B, D, and AMP-C, all kinds of extended spectrum, the ESBL type of beta-lactamases also. So at this point in time, for Feropanam, it is not a concern. But yes, if you again get into irrational usage and we do not resort to the antimicrobial stewardship as we spoke before, definitely the microbes are eventually going to find their way. We have to find a balance between optimal therapy and treading dangerously. So at this point, I would say we could use Feropanam for about 2 to 3 weeks safely. And at that point, we should be prudent enough to say stop, or whether we have reached the end of clinical treatment. Definitely using any molecule for 2 days, 3 days, like some of our colleagues might resort to practice, might be a dangerous trend. At least do a 5 to 7 day course if the renal profile allows.
Thank you, sir. And one more question from Dr. Jayabharati Tangaraj. Does it cross blood-brain barrier?
So the blood-brain barrier penetration of Feropanam is lower compared to the carbapenems. Definitely, if the infection is, if you feel that the infection is going towards the brain space, then definitely we may have to reconsider Feropanam. It might not be the best option if there is CNS involvement.
Thank you so much, sir. Thank you so much, sir, for this webinar. 447 ENT surgeons are actively logged in and they were watched. And Dr. Jayabharati sir is thanked you for your response. Thank you so much, sir, for your deep insights on role of clinical use of Feropanam in ENT practice. With your permission, we will close this link, sir.
My thanks and regards to Microlabs for having this session today to talk about Feropanam. It was a pretty educative session for me as well. And I would like to thank all the participants who sat down for half an hour, giving their precious time to listen to this webinar. Thank you very much and have a great day.